Welcome to the IPNA online educational series for general practice nurses. My name is Teresa Lowry-Lanin. I'm a member of the Carlow branch of the IPNA, and today we will be discussing thyroid disorders. The thyroid gland is an endocrine organ situated in the neck between the C5 and T1 vertebrae, anterior to the trachea and inferior to the larynx. It plays a major role in the metabolism, growth, and development of the human body. The thyroid gland regulates a wide range of physiological functions in the body through the secretion of thyroid hormone. Its hormones regulate basal metabolism, oxygen use, nutrient metabolism, the production of ATP, and calcium homeostasis. They also contribute to protein synthesis and the normal growth and development of body tissues, including maturation of the nervous system and increase the body's sensitivity to catecholamines. Wing-shaped left and right thyroid lobes flank the medial region called the isthmus. The parathyroid glands, responsible for the production of PTH, which control calcium levels in the body, are situated on the posterior surface of the thyroid lobes. The functional unit of the thyroid gland is the follicle, a roughly spherical group of cells arranged around a protein-rich storage material called colloid, which is the center of thyroid hormone production. Hormones are produced in the colloid when atoms of the mineral iodine attach to a glycoprotein called thyroglobulin, which is secreted into the colloid by the follicle cells. The thyroid gland produces thyroid hormone, which includes levothyroxine, which is T4, and triiodothyronine, which is T3, under the direct control of thyroid-stimulating hormone secreted from the pituitary gland. TSH is under the control of thyrotrophin-releasing hormone secreted by the hypothalamus. Regulation of thyroid function depends on normal functioning of the hypothalamic pituitary thyroid axis via a negative feedback loop, whereby precise control of the axis is maintained by the inhibitory actions of T4 and T3 on both TRH and TSH secretions. Serum thyroid stimulating hormone is sensitive to small changes in TH concentrations. A 50% reduction in free T4 produces a 90-fold increase in serum TSH. T3 is the active form of TH and has a shorter half-life in the circulation compared with T4. Most of the T3 in the body results from deiodination of T4 in the peripheral tissues. More than 99% of circulating thyroid hormone is bound to protein, primarily thyroid binding globulin, known as TBG. The levels of free circulating thyroid hormone remain normal irrespective of the concentration of binding proteins, and this is important for the interpretation of thyroid function tests. Let's now look at hypothyroidism. Hypothyroidism, better known as an underactive thyroid, is an endocrine disorder caused by decreased thyroid function. It is one of the most common conditions seen in clinical practice. Hypothyroidism often results from dysfunction of the thyroid itself, but can also occur because of defects along the hypothalamic pituitary axis or from intake of lower than required doses of exogenous thyroid hormone in patients with primary hypothyroidism. Hypothyroidism is more common in women and in people over the age of 60. It is among the most frequent chronic diseases in the elderly, and levothyroxine is within the 10 most prescribed medications worldwide in the general population. In Ireland, levothyroxine is one of the most frequently prescribed medicines on the community drug schemes, reflecting a high level of hypothyroidism in clinical practice. A deficiency of iodine in the diet is the most common cause of hypothyroidism worldwide. In countries with enough iodine in the diet, the most common cause of hypothyroidism is the autoimmune condition known as Hashimoto's thyroiditis. Less common causes include radioactive iodine injury to the hypothalamus or the anterior pituitary gland, certain medications such as lithium, a congenital non-functioning thyroid at birth, or previous thyroid surgery. The thyroid gland is the main site of iodine uptake in the body, which is incorporated into thyroid hormone. The recommended daily intake of iodine for adults is 150 to 300 micrograms. The highest dietary iodine content is found in fish, with smaller amounts found in milk, eggs, and meat. Reduced iodine intake is the principal cause of thyroid disease worldwide. Intake of less than 50 micrograms per day is associated with reduced thyroid function, either hypothyroidism in adults, cretinism in the presence of inadequate intake from birth, or goiter, whereby the gland size increases to compensate for the lower iodine in an effort to maintain normal thyroid hormone levels. Reduced thyroid hormone levels in hypothyroidism are associated with metabolic slowing, leading to an array of signs and symptoms, including fatigue, reduced exercise capacity, muscle weakness, weight gain, bradycardia, cold intolerance, slowing of the normal reflex, constipation, depression, menstrual irregularities, and in severe cases, hypothyroidism can result in pleural or pericardial effusion or even rhabdomyolysis. Blood tests measuring thyroid stimulating hormone and thyroxine levels are required to make a diagnosis of hypothyroidism. The normal reference range for TSH is 0.4 to 4. However, the range may vary according to assay and laboratory. Free T4 and sometimes free T3 levels may be required if the diagnosis is uncertain. The presence of specific anti-thyroid antibodies confirms autoimmune thyroiditis, but may not always be found. An elevated TSH level and a low T4 usually diagnose hypothyroidism. In most patients with hypothyroidism, the condition is permanent and requires thyroid replacement hormone therapy for life with a goal of maintaining euthyroidism, which is normal thyroid gland functioning. Treatment of hypothyroidism is with the synthetic prohormone levothyroxine, commonly known as L-troxin. T4 is the replacement therapy of choice because of its long half-life, once daily administration, and low cost. Because levothyroxine has a biological half-life of approximately a week, once daily dosing gives near steady state concentrations of T4 and T3. Full thyroid hormone replacement with levothyroxine is typically 1.6 micrograms per kilogram of body weight, provided daily, although in patients with significant obesity, lean body mass may need to be considered for initial calculations to avoid overtreatment. The starting dosage depends on the age, clinical status, and thyroid stimulating hormone level of the patient. For patients less than 50 years of age with no evidence of cardiovascular disease, a starting dose of 50 to 100 micrograms per day of T4 is recommended. In older patients and those with cardiovascular disease, the starting dose should not exceed 50 micrograms. In the presence of severe cardiovascular disease, this may be further reduced to 25 micrograms. Response to T4 therapy is monitored by thyroid stimulating hormone levels, taking into account the time lag in TSH response and the dosage increased at 25 to 50 microgram increments up to a maximum daily dose of 200 micrograms until clinical evidence of normal function is present and thyroid stimulating hormone levels are restored to within the normal range. T4 replacement therapy is for life, except in the case of post-viral or postpartum thyroiditis. T4 should be taken on an empty stomach in the morning. It should not be taken at the same time as certain mineral or vitamins that interfere with the absorption, such as calcium. Microsomal inducing enzymes such as rifampicin and carbamazepine enhance metabolism. The dosage of concomitant medications, example for CVD, diabetes mellitus, and anticoagulation, may need to be readjusted when normal thyroid function is restored. Side effects are usually due to excessive dosage for the individual and include GI disorders, palpitations, and myalgia. These are, however, reversible upon reduction of the dosage. Most patients with symptomatic hypothyroidism begin to notice an improvement within several weeks of commencing treatment, although resolution of symptoms once maintained on a stable dose may not occur for several months. If a patient continues to have clinical symptoms despite treatment and return of TSH levels to within the normal range, certain factors should be considered. Suboptimal compliance or problems with absorption will require further investigation. Where the TSH is just below the upper level of normal, but the patient is still clinically hypothyroid, T4 dosage adjusted to achieve TSH levels at the lower level of normal is recommended. Concomitant illnesses such as depression, often associated with Hashimoto's thyroiditis, may occur and need to be treated independently. Occasionally, a patient may require both T4 and T3 replacement in order to restore physiological functioning. However, routine use of a combination T4 and T3 therapy is not recommended as its benefits have not been confirmed by clinical studies. Let's now examine hyperthyroidism. Hyperthyroidism, or an overactive thyroid, occurs when the thyroid gland produces too much of the hormone thyroxine. Hyperthyroidism can accelerate the body's metabolism, causing unintentional weight loss and a rapid or irregular heartbeat. Common symptoms of an overactive thyroid include nervousness, anxiety and irritability, hyperactivity, mood swings, fatigue, difficulty sleeping, sensitivity to heat, muscle weakness, diarrhea, frequent urination, persistent thirst, itchiness, and loss of libido. Signs of hyperthyroidism include a goiter, a rapid resting heart rate, uncoordinated heart rhythm, tremor, warm moist skin, redness of the palms of the hands, loosening of nails in the nail beds, urticaria, alopecia, and twitching. This image can be used to compare the different symptoms which occur with the two different conditions, hypothyroidism and hyperthyroidism. Let's now consider the causes of hyperthyroidism. Graves' disease, which is an autoimmune condition, is the most common cause of hyperthyroidism, accounting for 80% of hyperthyroidism in iodine-replete areas. It is due to the production of anti-TSH receptor antibodies, which stimulate the thyroid gland, resulting in overproduction of thyroid hormone. The male to female ratios vary, and the peak incidence is between 40 and 60 years of age, although it can occur at any age. It can run in families and is also more common in smokers. Ocular symptoms diagnostic of Graves' disease include proptosis, extraocular muscular problems, diplopia, corneal problems due to lid closure failure, and sight loss due to optic nerve compression. The next most frequently occurring cause of hyperthyroidism is autonomous overproduction of thyroid hormone by either a solitary thyroid adenoma or multinodular goiter. Nodules that contain abnormal thyroid tissue are described as toxic. Toxic multinodular goiter occurs where there are two or more nodules in the thyroid gland. Solitary thyroid adenoma accounts for about 5% of cases of hyperthyroidism. Occasionally, a viral infection can affect the thyroid gland, causing thyroiditis. Postpartum thyroiditis can also occur. Other uncommon causes include iodine-containing drugs such as amiodarone and iodine-induced hyperthyroidism, sometimes referred to as Jod-Basedow phenomenon. The signs and symptoms of hyperthyroidism relate primarily to overstimulation of the cardiovascular, gastrointestinal, and nervous systems. Younger people with thyrotoxicosis may present with any of the symptoms, but older individuals are more likely to present with cardiovascular disease such as atrial fibrillation and heart failure. Although all patients can present with ocular symptoms, certain ocular signs and symptoms are diagnostic of Graves' disease. More than 80% of patients with Graves' disease are noted to have eye involvement on orbital imaging, although this is clinically apparent in only about 30 to 50% of patients. Any history of interference with vision requires emergency referral to specialist services. Untreated hyperthyroidism may lead to cardiovascular disease and severe thyrotoxicosis known as thyroid storm. This very rare condition, usually precipitated by infection, is associated with a mortality of 20 to 50%. The diagnosis of hyperthyroidism is confirmed by physical examination and blood tests. If the thyroid stimulating hormone is below the reference range and the thyroxine above the range, this usually indicates an overactive thyroid. Free T3 levels may be helpful to confirm the diagnosis, especially if T3 toxicosis is suspected with normal T4. The presence of anti-TSH receptor antibodies is diagnostic of Graves' disease, and the presence of other anti-thyroid antibodies may be helpful in diagnosing autoimmune thyroiditis. Treatment options include pharmacotherapy, surgery, and radioactive iodine. Treatment is tailored to the individual patient, taking into account the likelihood of remission with medication alone, goiter size, presence of comorbidities, patient preference, and the potential of future pregnancy for females. Individuals with confirmed hyperthyroidism should be referred for specialist care in order to optimize their management plan. Antithyroid drugs known as thionamides inhibit the production of thyroid hormone in the thyroid gland by interfering with the iodination process. They may have an immunosuppressive effect, which can be beneficial in promoting remission in autoimmune hyperthyroidism. Carbimazole is usually commenced at a daily dose of 20 to 60 milligrams, titrated against thyroid function until the patient is euthyroid, which is usually accomplished by week 4. Maintenance therapy is usually within the range of 5 to 15 milligrams per day, is continued for up to 18 months according to the response. Common side effects include skin rash, pruritus, arthralgia, and GI upset, which are usually self-limiting. A rare adverse drug reaction is agranulocytosis. Cholestatic jaundice can also be a rare side effect. A full blood count should be checked regularly, especially in the early months of treatment, and patients advised to seek immediate attention if they develop a sore throat, fever, or other symptoms of infection. In addition, patients may require a beta blocker to alleviate tremor, palpitations, and sweating while thionamides take effect. Atrial fibrillation should reverse once normal thyroid function has returned. However, if AFib is still present at 12 weeks, it is unlikely to reverse and the need for anticoagulation should be considered. Patients with ophthalmic Graves' disease require a specialist review. Let's now consider subclinical thyroid dysfunction. Subclinical hyperthyroidism is defined as low serum TSH but normal free T4 and T3 in the absence of hypothalamic or pituitary disease, non-thyroidal illness, or medication that inhibit TSH secretions such as glucocorticoids or dopamine. The causes of subclinical hyperthyroidism are divided into two subgroups, exogenous and endogenous. Exogenous subclinical hyperthyroidism results from thyroid hormone replacement therapy. The endogenous causes of some subclinical hyperthyroidism are similar to causes of overt hyperthyroidism. Graves' disease is the most common cause in young people, whereas toxic nodular goiter, solitary or multinodular, is more common in the elderly. Subclinical hypothyroidism is defined as a raised serum TSH above the reference range with a normal free T4 and T3. It is the commonest type of subclinical thyroid dysfunction and is most often due to chronic autoimmune thyroiditis. It increases with age and affects up to 18% of the elderly, with a higher prevalence in women than men. Data has shown an increased risk of coronary heart disease, heart failure, and cardiovascular mortality among affected adults. Conflicting results have been found with the association between subclinical hypothyroidism and cognitive impairment, depression, and the risk of fractures. Management strategies include screening and treatment of subclinical hypothyroidism are still controversial. Although thyroid cancer is rare, it is still the most common form of endocrine cancer. Approximately 162 people are diagnosed with thyroid cancer each year in Ireland, 117 women and 45 men, according to the Irish Cancer Society in 2014. Thyroid cancer can now be diagnosed early due to better diagnostic techniques. The most common thyroid cancers are known as differentiated. These include papillary and follicular cancers. Papillary carcinoma is the most common thyroid cancer, especially in younger people and particularly women. Follicular carcinoma is less common and tends to occur in slightly older people. These types of cancers are usually treated with surgery and radioactive iodine treatment. Prognosis for patients with differentiated thyroid cancer is very good, with approximately an 80 to 90% cure rate. Most thyroid cancers can be treated successfully with surgery, radioactive iodine, or a combination of both. Less common types of thyroid cancers are medullary, anaplastic, and lymphoma. Medullary carcinoma is a rare cancer that is sometimes hereditary. Most thyroid cancers are treatable and curable, but it is possible that they will reoccur, so lifelong follow-up is very important. Now we will look at thyroid dysfunction and pregnancy. Pregnancy can greatly affect the functioning of the thyroid gland, and it is associated with a 10 to 40% increase in the size of the gland, a 50% increase in the production of T4 and T3, and a 50% increase in the daily requirements of iodine. These physiological changes can render a pregnant iodine-deficient euthyroid woman in the first trimester hypothyroid during the later stages of pregnancy. Hypothyroidism can make conception difficult. However, it should be suspected in pregnant women with vitiligo, premature grey hair, or a positive family history. Pregnant women already on T4 replacement therapy will require increased dosage during their pregnancy to achieve normal TSH levels. The prevalence of hypothyroidism during pregnancy is estimated to be 0.3 to 0.5% for overt hypothyroidism and 2 to 3% for subclinical hypothyroidism. Thyroid hormone is critical for fetal brain development. In the first trimester of pregnancy, the fetus is completely dependent on the mother for the production of thyroid hormone. The fetus starts to produce its own thyroid hormone from 16 to 20 weeks gestation, but it still requires the mother to ingest adequate amounts of iodine to aid production of thyroxine. Untreated hypothyroidism is associated with complications in pregnancy, such as spontaneous miscarriage, maternal anemia, preeclampsia, small for gestation age babies, preterm birth, and postpartum hemorrhage. Levothyroxine requirements in pregnancy frequently increase by 25 to 30%, and in some women by up to 50%. TSH and free T4 levels should be checked once a pregnancy is confirmed. TFT should be monitored every 4 to 6 weeks until levels become normal, and trimester-specific ranges should be used while testing. It is important to remind patients not to take mineral or vitamin supplements at the same time as their T4 medication. Antenatal vitamin supplements containing iron and calcium can impair the absorption of thyroid hormone from the gastrointestinal tract. Thyroxine should also be taken either 1 hour before or 2 hours after food. Postpartum, the woman can usually return to her pre-pregnancy dose of levothyroxine. TFTs should be checked at the 6-week postnatal appointment. Hyperthyroidism can complicate pregnancies, although its incidence is less than hypothyroidism. Gestational hyperthyroidism is the most common cause, accounting for 1 to 3% of cases, and is characterized by transient hyperthyroidism limited to the first half of pregnancy, characterized by elevated FT4 or adjusted T4 and suppressed or undetectable serum thyroid stimulating hormone in the absence of serum markers of thyroid autoimmunity. It is thought to occur because of high hCG levels and may be associated with hyperemesis, multiple gestation, hydratiform mole, or chloricarcinoma. Graves' disease is the second most cause of hyperthyroidism, accounting for 0.1 to 1% of cases, and may be diagnosed for the first time during pregnancy or be present as a recurrent episode. Other causes include toxic multinodular goiter, toxic adenoma, and fastidious thyrotoxicosis. Postpartum thyroiditis is the occurrence in the first postpartum year of thyroid dysfunction in previously euthyroid women. Postpartum thyroiditis is characterized by transient thyrotoxicosis, followed by transient hypothyroidism, with an eventual return to a euthyroid state by the end of the first postpartum year. The initial thyrotoxic phase usually occurs about 3 months after delivery of the baby and is characterized by nervousness, irritability, and palpitations. These symptoms are often falsely attributed to anxiety neurosis occurring after childbirth. Postpartum thyroiditis is an exacerbation of an underlying autoimmune thyroiditis, aggravated by the immunological rebound that follows the partial immunosuppression of pregnancy. It is associated with the presence of anti-thyroid antibodies in the first trimester, with increased titers conferring an increased likelihood. Women with other autoimmune disorders such as type 1 diabetes and systemic lupus erythematosus also have an increased risk. This is a list of the references that were used in the production of this presentation. I hope you enjoyed this presentation on thyroid disorders, which is part of an online educational series for general practice nurses produced by the Irish Practice Nurses Association. My name is Teresa Lowry Lanin. I'm a member of the Carlow branch of the IPNA. Thank you.